All right, well, thank you for the introduction, Julia. So without further ado, we'll just kind of jump right into this presentation on outsmarting the bug, leveraging beta-lactam, PKPD, and Pseudomonas aeruginosa infections. So our objectives today are going to be to recognize the impact of antimicrobial resistance in Pseudomonas aeruginosa infections, as well as describe how PKPD principles can be used to overcome resistance. So I just wanted to start off by talking a little bit about the etiology of Pseudomonas aeruginosa resistance. And while there is a lot on this slide, I'm not going to belabor you guys and go over all of this. Really, I think the key takeaway here is knowing that there are a lot of different mechanisms of Pseudomonas resistance, specifically the intrinsic resistance that can lead to difficulties when it comes to selecting antibiotics. So normally when we think about empiric options in gram-negative infections, we have a pretty big list of things that we can pick from, whether that's beta-lactams, fluoroquinolones, or other antibiotics. We have plenty of options. But like I mentioned, with Pseudomonas and its multiple different mechanisms of resistance, those options are limited right out from the start. So we have to really be cognizant of the antibiotics that we have available to us that aren't intrinsically resistant, and just think about that going forward when we select antibiotics. This leads to a really like a major threat of resistance when it comes to Pseudomonas aeruginosa. Specifically, the CDC has labeled it as a serious threat, and data from 2017 estimated nearly 33,000 cases of hospitalized patients with resistant Pseudomonas isolates, 2,700 deaths estimated in 2017, and nearly $750 million estimated attributable healthcare costs in that year as well. When it comes to the epidemiology of Pseudomonas resistance, it is a variable prevalence of these multi-drug resistant isolates across the country and outside of it. This variable prevalence can even differ between wards in a hospital or one ICU or another. So it's just something to kind of be cognizant that this could be can really be different wherever you are. And specifically here at Norton Healthcare, there are no antibiotics that are 100% susceptible to Pseudomonas aeruginosa. I thought I wanted to talk about a little bit about some of our escalating Pseudomonas coverage before we get into some more detail about what we're going to be talking about, the PKPD principles. Specifically, beta-lactams are generally considered the first-line agents for gram-negative infections, and that's no different for Pseudomonas aeruginosa. So generally, we'll look to things like piperacillin tazobactam, cefepime, ceftazidime, or aztreonam to start off our empiric therapy, while other options like fluoroquinolones with ciprofloxacin and levofloxacin might have a role in oral options as they're the only oral options for Pseudomonas aeruginosa. And we also have antibiotics like aminoglycosides such as tobramycin and amikacin that can also be used for Pseudomonas infections. But there is a bit more concern when we use these as monotherapy, especially in more severe infections, and then concerns with toxicity as well there, which we'll talk about in a little bit. But specifically, normally when we think about escalating coverage, we think to look to carbapenems when we have resistance to antibiotics such as piperacillin tazobactam or cefepime. With Pseudomonas, though, it is interesting that we might see meropenem or imipenem resistance, mainly due to mutations in porin channels on the Pseudomonas that leads to resistance to only the carbapenems, but retains some activity against antibiotics like pip/tazo or cefepime. But when we come to resistance with all of the above, that's when we've run into more problems. Recently, there have been newer beta-lactamase inhibitors, such as ceftolozane tazobactam, ceftazidime avibactam, and imipenem relibactam, that have been utilized for these severely resistant Pseudomonas aeruginosa isolates. And then even more recently with cefiderocol used to treat the most extremely resistant isolates. So if we have these that are so adept at treating the very resistant Pseudomonas isolates, you might be wondering, why don't we just use these all the time? Well, we do still want to limit these newer beta-lactams, preferentially for preserving susceptibility for when we need them most. It's really important that we have to keep in mind that while these antibiotics are going to be utilized for extremely resistant Pseudomonas isolates, they're also utilized in other extremely resistant gram-negative infections outside of Pseudomonas. So we really want to ensure that we have the susceptibility and save them for when we actually need them as last line agents. Additionally, the cost with these newer beta-lactams is significantly higher than it is with older beta-lactam options. And we can see differences from hundreds of dollars in treatment with some of the older agents to thousands of dollars with newer agents. And this can even be exacerbated even more when we have longer treatment durations with things like osteomyelitis or endocarditis. So, as really a key takeaway from that, I think it's really important that we just strive to aim to utilize narrow spectrum antibiotics when you can, just so we can manage and preserve that susceptibility, like I mentioned. And now, just as kind of an example of selecting the narrowest option, this is what we'd all like to see whenever we see Pseudomonas. It obviously does not end up looking like this as often as we'd like, but when it comes to something like a pan-susceptible Pseudomonas, picking the narrow option is a little bit easier. However, when we get to more resistant isolates like this, the options become a lot more difficult. And before we start kind of talking about picking through this, I really wanted to touch on kind of explain what we're looking at here with the MICs and the resistant, intermediate, and susceptible isolates. So specifically, MIC is the minimum inhibitory concentration, and this is basically showing us the effect that a drug is going to have on a bug. So this is the lowest concentration that prevents growth of the bacteria, the lowest concentration of the drug that prevents growth of the bacteria, and really helps us guide antibiotic selection. Specifically, breakpoints with these MICs help determine and interpret the value of the MIC. So just to kind of go into that a little bit further, susceptible isolates are isolates where we're going to expect efficacy with standard dosing at or below this MIC. So we're likely going to achieve our treatment goals when the isolates are a susceptible MIC or below that. Intermediate MICs are where we're going to start to expect more kind of variable response rates to the antibiotics, and we might have lower response at this MIC, but still some patients might see response in treatment here. Whereas resistant isolates, these are where we're going to stop seeing efficacy altogether or very limited efficacy at or above this MIC with standard dosing. And so I just kind of wanted to highlight specifically as an example to kind of contextualize this, meropenem breakpoints for Pseudomonas aeruginosa. So as you can see here, when the MIC is less than or equal to 2, it's susceptible. When the MIC is 4, it's an intermediate. And when the MIC is greater than or equal to 8, it's resistant. And these MIC breakpoints are all based on 2 regimens, meropenem 500 milligrams IV every 6 hours and 1 gram IV every 8 hours, both infused over 30 minutes. And so I just wanted to come back to now to this resistant Pseudomonas isolate, just to kind of talk about what options we might have here. So as you can see, we have resistance to our newer beta-lactamase inhibitors with resistance to ceftazidime avibactam and an intermediate result to ceftolozane tazobactam. So out the gate, we're already looking at this and thinking, well, we don't have a lot of options. As we mentioned before, tobramycin, it is susceptible here, but we do have concerns with toxicity with aminoglycosides, including nephrotoxicity and ototoxicity, as well as concerns for efficacy when we use it by itself, especially in severe infections. But if you do notice here with the meropenem that we have an MIC of 4 and an intermediate result. And as I mentioned before, there might be instances where this intermediate MIC can still achieve treatment at the standard doses. So is there any way that we can optimize meropenem dosing to spare newer beta-lactam antibiotics like cefiderocol? So to kind of get into that more, we really need to just have a brief talk about PK/PD. So the PK of this is pharmacokinetics, and this is how the body affects the drugs, while the PD is pharmacodynamics, or how the drug affects the body, or in this case, the pathogen. And this is kind of exemplified by the MIC when we think of ID. So the big thing to think about with PK and PD is combining them and getting our targets. So our PK/PD targets essentially predict our antibacterial activity of the different drugs. And I just kind of wanted to spend a little time talking about different PK/PD targets for different antibiotics. So just to kind of help orient with this graph, we have the unbound concentration or the amount of drug that's in the blood and the y-axis, and then time down here. This line here represents the drug exposure, and this red dotted line is our MIC. So the first one I wanted to point out is the ratio of the Cmax over the MIC, or looking at the peak drug concentration above the MIC. This is best exemplified for Pseudomonas with aminoglycosides. And with this, we really care about maximizing our ratio of peak drug concentration over the MIC to get our efficacy, to hit our PK/PD target there. While quinolones, on the other hand, as the example for Pseudomonas, are looking to maximize their total drug exposure with this area under the curve right here. So as opposed to the aminoglycosides, we're really caring more about how much of this area we're shading in rather than getting to here and maximizing our peak above the MIC. And lastly, we'll talk about antibiotics that try to maximize their time of free drug above the MIC, and this is beta-lactam antibiotics, which we'll talk more about here in a second. But the key difference here is while we do care about how much we get over the MIC, we're really concerned with how long we remain above the MIC. So this triangle right here best exemplifies the beta-lactam's PK/PD target. And as I mentioned, this target is the time of free drug above the MIC. And luckily for us, there are multiple strategies that we can use to optimize this PK/PD target and increase our efficacy of beta-lactam antibiotics, including meropenem. So as a way to just kind of contextualize how we can take advantage of different dosing strategies, I wanted to show you guys this graph because I thought it does a really good job of this. On the y-axis, we have the concentration of antibiotic, and on the x-axis over here, we have the hours that the drug has been infused since administration at 0. So we also have this dotted line, our MIC. So traditional intermittent infusing dosing strategies, this is what you typically see when you infuse a beta-lactam antibiotic, so for over 30 minutes, for example. So as you can see here, when we have a 30-minute infusion, we have a quick peak up, but our MIC, or time above our MIC, drops off at around 4 hours. Whereas if we prolong our infusion to 3 or 4 hours for the infusion time as opposed to 30 minutes, we now have a lower peak, but we maximize the area, the time above our MIC, which is our true PK/PD target for beta-lactams. And we can augment this even further by simply having an infusion run continuously, as exemplified by this dotted green line right here, and just really trying to maximize our time that's above the MIC. And we can augment these things in a few other ways as well. With traditional dosing, we can dose more frequently, so that way we have less time below the MIC and can maximize our time above it. And we can also, with prolonged infusions, potentially give a loading dose before it, so we can bring our MIC, or bring our concentration above the MIC quickly and then keep it above the MIC for longer periods of time. But the importance of this is really to determine our probability of target attainment, or the PTA. So this is just our probability of achieving a set PK/PD target at different MICs. The PTA helps us to determine optimal antibiotic regimens, and that's why we really try to think about this for different patients and in different disease states and different MICs. So as a way to kind of contextualize this, I wanted to just show a example population of how different doses can affect their PK/PD targets and their probability of target attainment. So let's take, for example, this group of 8 patients. With one dose of antibiotic, they might have 5 of the 8 patients might have their PK/PD target achieved. However, when we look at another dose at the same MIC for the same organism, this now might be 7 of the 8 patients have achieved their target goal. Whereas a third dose might even get us to all 8 patients reaching their PK/PD target. So coming back to that meropenem with the MIC of 4 and the intermediate result, there's actually been population PK/PD modeling that have been used to find optimal meropenem regimens at different MICs. And with these population PK models, we've actually found that multiple different meropenem regimens can achieve this probability of target attainment at an MIC of 4. And really, when we think about this, we want to make sure that we're as close to achieving that 100% as possible. So oftentimes we'll see at least a 90% cutoff for where we want to find an optimal regimen. And as a way to just kind of help see this in a different way, I wanted to show this example of a probability of target attainment graph to kind of help show this. So on the y-axis, we have our probability of target attainment, while on the x-axis, we have our MICs for meropenem. Specifically right here, I highlighted the 90% probability of target attainment cutoff so we can easily see what regimens might be an optimal regimen at different MICs. And right here, we also, each different line represents a different dosing regimen for meropenem specifically. So at our normal breakpoint of the MIC of 2, we can see that we have a couple regimens here that achieve this 90% probability of target attainment at normal renal function. Specifically, we have the 2 grams IV every 8 hours infused over 3 hours, as well as 2 grams IV every 8 hours infused over 30 minutes. When it comes to the intermediate MICs of 4 for our patient example or our susceptibility example, only the 2 grams every 8 hours infused over 3 hours remains an optimal regimen. And even going further to a resistant breakpoint of 8, we even still see this 2 grams IV every 8 hours infused over 3 hours as an optimal regimen at normal renal function. So the big takeaway from this is that dosing really matters. Whether or not we're using higher dosing or we're extending our infusions to kind of optimize our time above the MIC, dosing is really important. And if there's anything that we take away from this, I think that's probably the biggest one. And this is also something that might serve as an opportunity to spare our last line options and doesn't necessarily have to relate to just meropenem. Optimizing our PK/PD can go for other beta-lactams as well. We could use it for penicillins, cephalosporins, etc. It's not just limited to meropenem and Pseudomonas resistance. We can use it elsewhere. But you might be wondering too, if this is such an effective way at treating resistance and higher MICs, why don't we just do this for all beta-lactams and in all patients all the time? So there are a few limitations, one of which is tying up lines. When we have these infusions lasting for 3 or 4 hours, or even some of the continuous infusions that might be lasting even longer than that, we tie up lines, which can be difficult for patients that might require many other medications at the same time. This can also lead to delays in procedures if we have to wait for a patient to have their infusion continue to run while they might need a CT scan or something. And additionally, if we're using higher doses, there is the consideration of cost of extra antibiotic. So that's always a factor that goes into this as well. But in summary, it's important that we select narrow and appropriate therapy to preserve last line agents, and increasing our dosing or extending our infusions can allow beta-lactams to overcome resistance. And with that, I will take any questions that anyone might have about this presentation. And thank you all.
Does anybody have any questions? All right. I don't have any questions. I think it's always very interesting to hear these presentations, and then I appreciate the limitations to implementing what you talked about are very real. So working through those limitations, I think is clearly very important for our patients.
For sure.
So. All right. Well, thank you very much. And we will see everyone at our next grand rounds in February. Have a fantastic rest of your day.